Good evening, everybody. My name is Jeremy Welch. I'm a GP here in Tewkesbury, and we're joined tonight. We're very lucky to be joined by Mr. Ed Tudor, who is a urology consultant from Gloucestershire, who's been working here as a consultant specialist for the last 4 years, but's actually been in the area much longer. So thank you for everyone for joining us. We are presenting here from Tewkesbury, and on behalf of the Tewkesbury, West Cheltenham, Newington, Staunton primary care network. That's a joint of 5 practices working together. We're very aware that we are absolutely sitting in Gloucestershire, and if there's anyone from outside of Gloucestershire, you're absolutely welcome, but some of the messages may be slightly different about some of the services. So why are we here? We're here to talk about the prostate, and we're here to talk about prostate cancer. Prostate cancer is something that is out there. We're boys here tonight, and hopefully lots of boys listening tonight. Prostate cancer is something which we see on the news. We hear about prostate cancer, but we hear mixed messages, and we hear things that differ depending on what news bulletin we've watched or where we've looked on YouTube or on the internet. And so we're here really to try and demystify some of the confusion. There are some difficulties in prostate cancer. It is not crystal clear, and I think that's what drives that uncertainty and the nervousness across the population. But the facts are true. Prostate cancer is the most common cancer in men. More than 52,000 men are diagnosed with prostate cancer in the UK every year. That's 144 every day. Every 45 minutes, one man in the UK dies from prostate cancer. That's more than 12,000 a year. As boys, 1 in 8 of us will have prostate cancer across our lifetime. So those are big numbers. Those are scary numbers. And that's what we want to talk about, how we can help you to make the right decisions and be here as your GP and your specialist. And we're joined by our specialist nurse, Anne Williams, who will be fielding your questions and sharing questions with us as they come up. Prostate cancer doesn't choose. Prostate cancer chooses any men. Andrew Lloyd Webber from music, Stephen Fry from celebrity and from literature, Roger Moore, James Bond, Ben Stiller, actor, Nelson Mandela, Ray Clements from football, Bill Turnbull from the BBC, Kenny Logan from rugby, Bob Willis from cricket, and many, many more. So it is absolutely out there, and we're here to try and help to answer some of your questions. As a GP, I see men anxious, worried every single day of the week. I'm often having this conversation about prostate that we're going to play through tonight, and we're very lucky that we've got a specialist to correct any mistakes I might make. But it's something that I almost want to sort of nip things in the bud and get that message out to people first, so they're informed. So without further ado, we're going to crack on with some questions. The way it's going to work tonight is I'm going to ask questions of Mr. Tudor and challenge, and just as I would if I were a patient, and absolutely one day I may be a patient asking these questions. We'll talk for probably about half an hour and hopefully address most issues that you guys and ladies watching have, but then absolutely we'll have some time afterwards to answer any questions that you may pose, and we've got some questions that have already come in. So I think first up, let's start with basics. Mr. Tudor, what is the prostate?
So I'll answer your question, but thank you for your warm introduction, Jeremy, and it's lovely to be here tonight, and hopefully I can help answer your questions and any questions from out there. Because as you just said, the numbers you just reeled off, they're scary numbers, they're high numbers, and it's a serious, significant disease. But the good news is that in Cheltenham Hospital, where I work as a consultant urologist, we've got a fantastic team. And we get good outcomes and good results. It's a very treatable disease to men who present early, and we catch it early. And in my job, I see a lot of men with prostate problems and raised PSA, which we're going to discuss in detail now. And I offer a variety of treatments for prostate cancer, including surgery to remove the prostate gland if required. And I see men through that process, and with my team, I get them better as well afterwards. And there's no doubt that we do save lives in that process. So, but this sort of awareness is fantastic because it highlights the disease, and people can be aware of it, and they can speak to their GPs, which is something we'll talk about. So going back to your first question, what is the prostate? Well, the prostate gland sits beneath the bladder and it surrounds the urethra, so deep in the male pelvis. And typically, as a younger man, we were taught it's the size of a walnut, but most of the men I'm seeing are in their 50s and 60s, and by that stage, it's a bit bigger than that, so the size of a plum or even a satsuma. And some men have prostates that do grow very large, and they can even be bigger than that, the size of an orange, or if not larger. And the joke is, what is it? Well, it's something that keeps me in work, because I see lots of men with prostate problems. But what does it do? Well, the purpose of the prostate is that it makes a lot of the liquid that a man sees in semen. So when a man ejaculates, most of that liquid is not sperm, which of course is made in the testes. It's liquid and nutrients that keep the sperm alive that's made in the prostate gland. So that's the point of it. It's designed to produce that liquid that keeps the sperm alive. And it's also got some fairly nuanced ejaculatory function. So when a man ejaculates, it's the prostate gland that propels the semen out of the penis and doesn't let it flow back into the bladder, where it would not be much use at all. So that's what it does. In health, it's normal for a prostate gland to get bigger as us men get older. So I'm sure we'll touch on that. But I see a lot of men who are worried about prostate cancer, but I also see a lot of men who have an enlarged but non-cancerous prostate, and that can cause other problems and symptoms, which I'm sure we'll discuss in the course of this discussion.
So we've done the prostate. The other big thing that's out there is, I'm going to jump straight to the PSA. That's a term that we've all heard. It's out there. The PSA, get the blood test, get the blood test. Everyone get the blood test. So what is the PSA?
So as you say, PSA is a blood test. So your doctor or nurse will check it by drawing a sample of blood out of a vein in the same way they test for all sorts of other conditions. PSA stands for prostate specific antigen. So as the name suggests, it is specific to the prostate gland. So if you don't have a prostate gland, you'll have 0 PSA. So a woman without a prostate gland will have no PSA in her bloodstream, for example. But it's normal for every man to have an element of PSA, even if you don't have prostate cancer. Mm-hmm. And so we look at the PSA and we have set thresholds, and if it's elevated above that set threshold, then we as doctors get worried that one of the potential causes for that elevation could be prostate cancer. But certainly it's not exclusive, because in health, a healthy normal prostate will produce PSA. So a larger prostate will therefore make more PSA. So a very common cause that I see for a man with an elevated PSA is an enlarged but healthy prostate. And part of our work together in primary care and in the hospital is to work out why your PSA is elevated. That's what we do, and work out whether it's cancerous and needs treatment or not. But a larger prostate will make PSA. And of course, and we also know that as a man gets older, his prostate naturally enlarges. So what we tolerate as being an acceptable PSA level increases with age, because as the larger the prostate gets, the higher the PSA is allowed to get as well, before we as doctors get worried about it.
So we're getting into the PSA in these levels, and we'll park that very temporarily. Before we're thinking about PSA, we're thinking about why would we check PSA. And so sometimes I talk about, and I'm sure you talk about as well, lower urinary tract symptoms, and the things that sort of prick our ears, and we ask patients, men to come in with, they're getting symptoms. Can you expand on what we mean by lower urinary tract symptoms?
Yeah, absolutely.
And what are
so these are so symptoms are things that a patient would experience. And a really good way that I broach that question with my patients is I might say, well, how is your bladder treating you? And typically as doctors, the symptoms that we're looking for that are due to an unhappy bladder, not necessarily cancerous, but unhappy, can include problems with passing urine, so struggling to wee with a slow flow of urine, straining, having to push the urine out because it feels like there's a blockage there. Other symptoms that men can complain about is getting up at night, and I'm sure that actually gets very common as us men get older. At least once a night, I would say, is normal. But I see some men who've got dreadful symptoms and are passing urine literally every half an hour at night, and then you wonder how the poor chap's going to need sleep. Mm-hmm. We can help with that. And then other symptoms, like in the daytime going too frequently or going too urgently. Those are symptoms that the bladder is not happy storing the urine. So a healthy bladder should relax, fill up, store urine, and then empty completely. But if you're struggling to empty and got a slow flow or straining, that can lead to one list of diagnoses. But equally, if your bladder's not storing urine properly and you're going too frequently, that can lead us to worry about other conditions. And there are some red flag urinary symptoms that we do worry about. And if you do have these, then you do need to speak to your GP about them. But particularly if you ever see blood in your urine, straight to your GP, and we will investigate that in the hospital. But also if you're having recurrent urinary infections, that's another type of urinary tract symptom, and your GP will be interested in that and trying to work out why they're occurring and help you treat them to stop them coming back as well. So those are the urinary tract, the lower urinary tract symptoms we talk about.
So often, probably in my world in general practice, I see these symptoms more, and often I'm challenged that, well, we 3 times at night, but I've done that since I was 20, and at that point I'm less worried. And so I often talk to people about changing symptoms. What's your baseline? What have you always done? If you're always a 3 times a night man, well, that's not ideal, but I'm less worried. And so just to summarize, it's I talk about hesitancy, the getting going, the initiation, and often I talk about people, if you go into the motorway services, that you've stood in urinals and 3 men have been in and out before you've even got going. Yeah. I then talk about the sort of the frequency during the day. So people are starting to comment, or you're thinking, oh, I'm getting up, going to the toilet a lot more than everyone else, and you've naturally started to reduce your tea and coffee, thinking that will solve it. I talk about the night one. The night is what often people see us with, because that's what really packs people off. That's
the bother, isn't it? And often the wives also get disrupted because their sleep's disrupted as well, so they nag their partners come in. But if you're getting up at night to pee, you don't sleep as well, and that, as you say, that's the problem. If you're not doing much in the day, you can tolerate going to the loo every hour sometimes, but it's the night time that, as you say, really causes the problems for a lot of men.
And then the fourth one for me is the dribbling, is almost closing off your prostate, that you may have a bit of, oh, hang on, I'm quite finished, a little bit more, or you may make a little bit of a mess on your underwear.
Yeah, exactly. So a lot of these symptoms we're talking about are often due to enlarged prostate, and because it surrounds the urethra, as it grows, it can grow into the urethra, and it's a bit like you've got your foot on a hose pipe. So when you're peeing, you've got increased pressure, so you're straining, your flow is weaker, you dribble at the end. As you say, you can hesitate or struggle to start weeing, so you're waiting for longer than you did when you were younger. And typically, my job as a urologist is to work out why you have those symptoms. But a common cause, especially in older men, is the prostate is enlarged. Now, we're here tonight to talk about prostate cancer. And it's much more common that if you have those symptoms, you don't have prostate cancer than you do, because enlarged prostate that causes those symptoms is very common in general. But what we're discussing here is that these symptoms, yes, they can be a herald sign of other troubles. So that's why it's important that if you do have these symptoms that are becoming more bothersome, you do discuss them with your GP. But if you have them, please don't be worried that you've got prostate cancer, because most men with these symptoms won't have prostate cancer.
That was the thing I was going to ask you about, and colleagues asked me about what sort of percentage patients who we may refer to the hospital, or actually, I guess I can ask ourselves that question, who have these increasing lower urinary tract symptoms go on to have prostate cancer. And it feels very low. A very small percentage of men have actually, unfortunately, do have cancer.
Yeah, I think it is very low. And as you will know as a GP, when you see a man, you will assess them, and that assessment will involve asking questions about the symptoms we've discussed. And then you'll examine the man. We'll talk about that. You may decide to do a prostate blood test, but not always. I'm sure we'll talk about that. And based on, as a GP, whether you're worried this man may or may not have prostate cancer, that will affect how you refer them into the hospital. Because if you are worried, we will get that man seen and diagnosed within a matter of weeks, if not less time than that. But that initial decision pathway starts with primary care. Yeah. So I think the answer to your question depends on which stream they're coming in. But yes. But in terms of if you're not worried, GPs have a fantastic clinical acumen, in my experience, from what I see from the referrals I get. But if you're not worried, then actually the risk of them having a significant prostate cancer actually is quite low. But I'm sure we're going to discuss now what we'll do to assess men.
So there's different points of entry. And so the first thing is these lower urinary tract symptoms. If you've got new symptoms, if things are changing, we want to see you as general practitioners, and we want to assess you. And so I guess this is my bag. So if a chap has new or increasing nocturia going to wee at night, and it's definitely different and it's definitely causing a problem, I would want him to contact the surgery. And at that point, I would see that gentleman. We'd have a general chat about how long it's been going on for. It's been a couple of months actually, and I've been meaning to. I thought it would get better, but it didn't. So that's pricking my ears up that actually I need to do a little bit more with you. I would have a general chat about how that person is. Have you put on weight? Have you lost weight? Are you exactly the same weight? Have you got any pains or any other concerns? No, I feel fine. Otherwise, it's just this. I'm a bit tired in the day. Probably, I think that's because I'm getting up to wee at night. At this point, we would do a few things. So there are some other conditions that possibly can give those symptoms, and so I'd want to check a wee sample. A wee sample checks you for diabetes, which can make you wee a lot as well. A wee sample also checks just to make sure there's no blood in your wee. And then we get on to the conversation about examining your prostate and potentially doing a blood test as well. So examining your prostate, I'm really sorry, chaps, there's only one way I can examine your prostate. And I think you all know what that is. That's the finger up the bum test because of where the prostate sits. It's a common test. We are doing it several times a week, all male GPs. It's honestly not going to be as bad as you think. Please don't be embarrassed. It's normal, and we're doing it, I say, most days of the week. I'll talk to a little bit. I don't want to put everyone off, but you lay on the couch, you roll onto your side, you pull your knees up and drop your trousers to half mast. I put some gloves on. I put some jelly on my finger. I warn you what I'm going to do. I'm going to put my finger into your bottom, and I'm going to feel your prostate gland to feel for the size of the prostate. I'm feeling for symmetry of your prostate. I'm feeling for any nobbles or bubbles or lumps in your prostate. And so that's what we call a DRE, or digital rectal exam, or prostate exam. So that's what you heard about. It's over and done in 30 seconds. I then have a chat about the PSA. So the PSA is the prostate specific antigen, as Mr. Tudor spoke about. Do we go ahead with the PSA? So it's not always entirely a straightforward question, this one. So the PSA can open a bit of a hornet's nest, because there are lots of men out there with a raised PSA that haven't got any problems, and that could be me. I guess it could be you. And so once we've taken it, then we've got that result, and we have to deal with it. And often that's a hard one. I think as a patient, I think, well, I want to know. But then when you do know, do you really want to know? Because it can set off a cascade of other tests. So.
And we'll talk about what those are. But I think we were discussing this before this event, and it's a really tricky one, because as a patient, you think, well, of course I want to know. But what we all crave as consultants and GPs and actually patients, what we need and what we don't have yet is a bulletproof test to see if you have prostate cancer, and screening, which is the realms of what we're starting to discuss now. We will talk in detail. Screening for diseases means you take a person who just has no symptoms of the disease and you test them for it. So, you'll be familiar with, in the NHS, we screen for breast cancer and cervical cancer, and that is offered to women who have no symptoms of breast cancer or cervical cancer. So obviously, if you feel a breast lump as a woman, you should go and speak to your GP and they'll arrange a mammogram. But the screening test for breast disease actually is for women who don't have symptoms. They can't feel a lump. And the point is, you're trying to catch the disease before it's symptomatic, before you can feel any abnormality, or in the context of prostate cancer, before it becomes too advanced and therefore harder to treat. The best way we can do this at the moment is with the finger in the bottom test, the rectal examination, and the PSA. But the problem we've got is that the PSA is not that reliable to look for prostate cancer, because there's lots of other things that will cause it to be elevated. And they include a non-cancerous enlarged prostate. They include going for a bike ride, because pressure of the saddle on your bottom will push on the prostate and make more PSA. They include ejaculation. So you've had sex recently, that will push the PSA up. And then other common causes are infections. So a urinary infection or prostatitis, infection of your prostate. These are not cancerous conditions, but they'll make the PSA go very high. So as doctors, we don't tend to check the PSA if we're at all worried that you could have an infection, because we know that result will be high. And as Jeremy says, once you've found that result, the question is, what do we do with it? And actually, as doctors, if we know you've got an infection and we know therefore your PSA is high, we wouldn't rush to refer you in to see a consultant. We'd say, well, let's just recheck the PSA over 6 weeks to see what it does. But that's the discussion that you struggle with, or not necessarily struggle, but it's a challenge for primary care GPs, because a lot of men may be asking for PSAs, and the reality is that we do it, it might be elevated. You could go through some investigations. They're not particularly pleasant, but sometimes are important. And at the end of it, the tests are negative, so you potentially put yourself at risk in the investigations unnecessarily. So the challenge for all of us is how we select the right men to be referred in to see me in the hospital. And it is a challenge, and we all struggle with that, because there's not an easy test that gives us the answer that we need.
I often tell patients, I remember 25 years ago, I can remember sitting in my lectures in medical school and being told about the PSA and being told it's quite a good test, but it's not a great test. Don't worry, you guys and girls, by the time you're qualified and you're doctors, we'll have a better test. And we're sitting here 25 years later, and we're still talking about the PSA. So we haven't come a lot further forward in PSA testing and screening, and we're just going to start that discussion on the thoughts about screening and where we are. We have come a lot further forward in treatment.
Absolutely.
But it's the picking up and the mass population screening. And I remember my public health lectures 25 years ago being told about these people, Wilson and Younger, who were public health consultants, and they looked at the criteria for a screening test, and they ran through sort of there's 10 points to this screening test, and Mr. Tudor's alluded already, and it's really about, is the test a good test? Will it pick up the right cancers? Will it conditions or cancers? If it does pick them up early, is it beneficial to pick up early? Is there a good treatment? And it just didn't pass the test back 25 years ago, and it still doesn't pass the test now.
So I think this is the sort of part of the meat of what we're going to discuss today, I suspect.
Yeah.
Screening is, so what you have to understand about screening is screening is testing a group of patients who have no symptoms, they don't feel unwell in any way, and then we're testing them to see if they have a disease. Now, in the context of prostate cancer, if you go to see your GP with significant urinary symptoms, then that's not, you don't need to be screened. You've got symptoms already, and it's likely your GP will examine you and then discuss with you the merits of doing the PSA test. We haven't touched on it yet, but there are other symptoms of more significant prostate cancer, which are rare. Most of the patients I see with prostate cancer, they do luckily present quite early, and therefore it's treatable. But rarely there are some more advanced symptoms. So they include blood in the urine, significant weight loss, and persistent, troublesome bony pain. Now, that's a bit of a can of worms in itself, because bony pain, aches and pains are really common as we get older. Arthritis is really common, but advanced prostate cancer, typically in older men, can spread or metastasize the bones, and then it can cause a gnawing, unrelenting pain. Typically, the bones, the hips, the thigh bones, and the back. And if you've got pain that keeps you awake at night and doesn't get better when you rest, then your GP will want to know about that. But that's not, again, it's not exclusively due to prostate cancer by any means. But those symptoms are due to more advanced disease. But screening, which is what we're talking about now, is really something that is relevant to many who have no symptoms at all. And the challenges with screening in prostate cancer are a number of factors. So the first is that, as we've alluded to, the PSA is not a great test to tell us if prostate cancer is present or not. Once I know a man has prostate cancer, it's a very good test to track how well that disease is responding to treatments. So if you diagnose them, they have a biopsy, which we might touch on. We get a formal diagnosis. And what I mean by that is we've taken a sample of the prostate and we've seen the cancer cells under a microscope. So we can say conclusively, yes, you do, or no, you don't have prostate cancer. Once we know that and we instigate treatment, the PSA then does become very reliable at monitoring the response to that disease. But up until that point, it's not a particularly reliable test at diagnosing it. So what I mean by that is that there's a lot of men who have an elevated PSA, but for the reasons we mentioned, they won't have prostate cancer. But also you may have a normal PSA, but still have prostate cancer. Because if you've got a small prostate gland that doesn't make much PSA anyway, you may have cancer that's elevating your PSA slightly, but it may still be within the normal threshold of what we consider normal. So the first problem with screening is there's not a test that's as reliable as, for example, a mammogram is to detect breast cancer, or a cervical smear test is to detect cervical cancer. So that's the first problem. And the second problem is that when we detect the disease, how much difference does that make? And that's a strange concept. But but prostate cancer is a very varied disease, and there's some men who present with very aggressive, life-threatening disease that's already spread, and those men, we can't cure them. However, there's still treatments, and there's a very good 5-year survival from treatment for men with metastatic prostate cancer. We quote 50% of men, so half of men with advanced prostate cancer, cancer that's spread, will live over 5 years because a lot of the treatments now are so good. But that's rare. That's rare to have advanced disease. A lot of men have intermediate risk disease or even low risk disease. And intermediate risk disease does need treatment, but even with treatment, you're not going to see a benefit from that treatment for 15 years plus in some men. And then there's another large group of men who will have prostate cancer, but their disease is so low risk that they will often never need treatment in their lifetime. And that's a really difficult concept as a patient, because you might be sitting in front of your consultant who might say, your biopsies do confirm cancer, but the cells, the individual cells we've seen on the microscope, they're so inactive, they're so dormant, they're so unlikely to spread in your lifetime that the treatments that I can offer are much more likely to cause you as a patient any more harm than the disease ever will. And that's when the PSA comes in, because then we're monitoring the PSA. And as long as it stays flat, no treatment is ever needed. So for these reasons, screening just doesn't work for prostate cancer. And there have been some enormous clinical trials across the world. Three-quarters of a million men have been enrolled. And what these trials have done is they've allocated men to PSA check versus no PSA check. And after many years, what they've found is in the men who do have a PSA check, and of course, don't forget, this is the asymptomatic men with no symptoms at all. But what they find is that whilst they do pick up more prostate cancer, they don't save any lives. So we are finding more disease. We are treating more men, but as a result of that, we're giving more men side effects. And at the end of the day, we're not saving any more lives than for men who didn't have screening. And that's a concept that's a real struggle to get your head around. It really is. Yeah. But that's what the science tells us.
It is a strange one, because you think, surely if I've got cancer, then I need to know it and I need to have treatment. And actually, I see these patients who they've come in with symptoms. It may actually not have been their prostate that's causing them symptoms. I've done the rectal examination. It's okay. I've done the PSA. It's slightly raised. I've referred to Mr. Tudor and his colleagues at the hospital. And they have, well, did you want to talk through it? There's a chap, let me say I'm 55. I've got a PSA of 5, a slightly enlarged prostate. My GP examined. What would you do with me then in the hospital?
So that's a really good question. So if you're referred in from Tewkesbury, where we are now, and you're referred to Cheltenham General, so I work in the Trust, Gloucestershire Hospitals Trust, but my department, the Urology department, happened is that your GP, Dr. Welch, will write to my team saying, I'm worried this man might have prostate cancer. Here are his symptoms. Here's his PSA. This is what I found when I've examined his prostate. And that referral will come into our department. And the first thing that will happen.
So that will come as what we would call a 2-week wait.
Yeah, exactly. Yeah. So the 2-week wait pathway, as you'll know, is if you see a patient with a red flag symptom for potentially any cancer, you will send them into the relevant 2-week wait pathway. So we've mentioned breast lumps, that will go to the breast team in the hospital. You're suspicious about prostate cancer because of worrisome symptoms, because of an elevated PSA that's not due to one of the things we discussed earlier, like a urinary infection, or because you feel the prostate is knobbly. So a knobbly prostate, when you examine a man with a finger in his bottom, potentially could be cancer. But again, it's not always. And it's not always. So don't be worried if your GP says your prostate feels irregular. Then you'll refer the patient in on a 2-week pathway to us. So what happens then? Well, one of my specialist nurses, who's extremely experienced in prostate cancer, will phone you. And you'll spend a lot of time on the phone to her, and she'll go through a lot of the symptoms that you've got, and those are the waterwork symptoms, the lower urinary tract symptoms we've discussed. She'll ask you all about those. She'll ask you about your health in general, any other medical problems, what medications do you take, what operations have you had before? And she'll ask you about risk factors for prostate cancer. Now, we haven't talked about those in detail yet. We just lost our screen, which is still live. Don't worry.
Sorry, I think we're back on.
So I'm not going to talk about risk factors now, but we will get onto those. But there are a number of risk factors for prostate cancer, so she'll ask you about those. And then most of the men who are referred on that pathway, they then get booked straight for an MRI scan.
Okay.
And that's before they even set foot into the hospital. So they're booked for the scan, and you'll get a letter or a phone call in the post, and you can expect to be called up to the hospital for a scan of your prostate, and that will either be done in Gloucester or Cheltenham. And an MRI scan takes about 30 to 40 minutes, and you lie flat. You go into a tunnel, and understandably, some patients are pretty scared about that because it is quite claustrophobic. However, if you let the team know that your whole body doesn't have to go into the tunnel, it can just be your prostate, okay, or your pelvis rather, and your head can stay out. So whilst you are in a bit of a confined tunnel, your head isn't necessarily always all the way in. And that scan takes about 40 minutes. And then it gets reported by a specialist consultant radiologist who's looked at tens of thousands of these scans, and he's pretty good at giving us a likelihood score. So that's the next thing, is that when we get the result of that scan, we don't get a diagnosis of prostate cancer. We get a likelihood score as to how possible it is that from the way your prostate looks, prostate cancer could be there. And that's also quite daunting, because a bit like the PSA is not 100% reliable, an MRI scan is not 100% reliable. And even with a man with a worrisome looking prostate, he may have other causes for that. And that could be things like infections again. So a worrisome MRI scan doesn't mean you've got prostate cancer.
So I've been to my GP, I've been referred, I've had a chat with your nurse who's asked me lots of questions. I've been through the MRI scan, and then do I get to see you after that?
So you don't at that stage. What happens next is the nurse will call you right to you saying, we're worried enough based on what you told me and the way your MRI scan looks, that you need a prostate biopsy. Okay. So to speed up the pathway and to get you to see me quicker and to get your diagnosis quicker, which is what we all want, especially the patients, we try and streamline the diagnostics. Okay. So it's likely at that stage, if your MRI scan shows any cause for concern, even if it's very subtle, we would recommend a biopsy. And of course,
if my MRI was clear, you're really happy with it, we'd stop doing nasty tests to me at that point.
We would.
Brilliant.
Yeah, we would. So if your MRI scan showed no significant prostate cancer, then we go back to your symptoms. And if you had no symptoms at all, I'd discharge you back to Jeremy, and I'd say MRI is all clear, and I would give a recommendation to you about PSA checking and looking out for other symptoms. Okay. But for a lot of men, that's the end of it. Thank goodness.
Good.
Shall I talk about biopsy?
Yes. Okay. So
would you like?
I wasn't fortunate
enough, or would you like to go on talk about something?
No, that's good. So let's replay through me. Let's say I'm 55 and I've had the scan, and it's not quite right, the scan.
Yeah.
So tell me what happens next.
So that's I'm going to pick you up what you just said there, because with the scan we don't get a normal abnormal, we get a gradient, and anything from not quite right to very abnormal we will offer a biopsy to. So if the nurse or the consultant is phoning you saying you need a biopsy, it's not because you've definitely got prostate cancer, it's because we just don't know. Okay. And the reason we're doing the biopsy is to find out. So what would happen is you receive an appointment to come into Cheltenham Hospital as an outpatient, and you can expect to be in the hospital for about an hour. A biopsy is not the most pleasant thing in the world, but it is important. And the consultants and clinicians that do it do hundreds of these. And we've got a fantastic team. And I think, honestly, most men have it. They say it wasn't the best thing in the world, but they do tell me, that it was better than they were expecting.
Yeah, I think sometimes as GPs, I might have slightly scared patients about the prostate biopsy. And actually, I'm very pleased to hear it's not quite as bad as I might describe to chaps.
Yeah, I mean, it's not the most comfortable thing. It's not particularly dignified, because we do ask our patients to sit or lie with their legs up as if they're a woman having a baby in that position. And then we have to scan their prostate with an ultrasound scan at the bottom. And using local anesthetics to the numb, we then take samples out of the prostate through the perineum, and that's the skin between the scrotum and the bottom. So it's not a dignified test, but you can be reassured that the team that are doing this see a lot of men in this position, and we look after them. Obviously, we'll treat you with respect and dignity, and we've done it thousands of times, and it is an important test. So we take a number of samples out of the prostate, and then you can leave almost straight away. It's quite common to see a bit of blood in your urine afterwards, and we'll tell you that beforehand. And I think it's also important to say that, of course, when you come to the hospital for the biopsy, that's the first time you'll be coming in to see anyone in the hospital, yes, having been referred. And you do get a chance to ask questions and say, look, what on earth is going on here? What does the MRI show? What are you going to do to me? And those are all very valid questions. And then the biopsies get sent off for analysis, and a pathologist will look at those samples, the tiny samples, they're millimeters in size, but they'll look at them underneath the microscope. And that's when we'll know for sure whether a prostate cancer is there or not. And
out of the sort of walnut or the plum, depending, how many biopsies are you taking?
We normally take about 20, and they measure 2 centimeters in length, and they're about 1 millimeter wide and thick.
Okay.
So they're tiny. They're the size of an opened up paperclip or something, or half that length. They're really fine samples. But we use the MRI to target the areas that looked abnormal when we're taking the samples. And those samples then sent off for analysis, and that's when we get the diagnosis.
Okay. I'm going to draw back a little bit from that. I mean, I think we will touch on treatment options,
we can.
But I just want to go back to screening, because screening is the big one. So the real nub of why we're here is, like, I'm 47. Should I have a PSA test?
So the cop out for me is that there is no screening program in the UK for prostate cancer at the moment. So the answer is, I'm not going to treat you as an individual, because that's very different. I'm going to treat the population as a whole. Yep. But as a whole, we don't offer screening, and the NHS does not recommend screening for asymptomatic men, because as I've alluded to, as I've said, the benefit for that does not outweigh the risk. However, there are men with symptoms, there are men with anxiety, and there are men with risk factors. And I think that's when it comes down to having a very frank discussion with your GP.
And one of the risk factors being age.
So we talked about this earlier, didn't we? Or I alluded earlier. So the risk factors for prostate cancer. So we talked about the symptoms, which are how you may feel, probably the waterworks, that kind of thing. But the risk factors are things that may increase your chances of getting a disease. So the common one most people know about is that smoking is bad for you, because it hugely increases your risk of getting lung cancer. Now, with prostate cancer, the common risk factors are the things that you can't control, and they are your age. As you get older, you're more likely to get prostate cancer. Your ethnicity. Black men are twice as likely to have prostate cancer. And also your family history. So if you have a brother or a father that was diagnosed at a youngish age, then you're twice as likely to have it. If you have a brother and a father, or 2 brothers, then that risk goes to 4 times. And if you have 3 first-degree relatives, then you're 11 times more likely to get prostate cancer. The risks really start to rise. But you've got to put it in context, because the older you are, the older your dad was when he got the disease, the more likely that was due to natural aging versus the genetics of it passing down in the family. And actually, prostate cancer in older men starts to get very common. And actually, it should really be regarded as a disease, a natural aging process. And we were discussing before this meeting that they did pathology samples in deceased men many years ago. And what they saw was that if you're 80 years old, there's an 80% chance you've got prostate cancer, which is really high. And it sounds really scary. But just to reassure you, the majority of those men, 90% of those men, will never know about it, because it's not dangerous disease. In those men, it's lower risk disease, and they will live out their natural life and never know about it, because it will never cause symptoms. And we say, you may say this as well, Jeremy, we say that men die of it rather than die from it. So I beg your pardon, they die with it, rather than die from it. And what that means is they live their life and they die of other natural causes. But prostate cancer was never something that caused them any harm.
I remember that study when I was back at medical school, and I was quite taken aback by it. But the truth is that those men over the age of 80% of them had prostate cancer, and actually they didn't need to know it.
They didn't,
it
exactly.
Probably would have made their life worse if they knew it, because they would have had that worry.
It's really scary. Yeah.
Is it going to do something? How many tests should I have? Should I have my prostate cut out? And I know we probably used to be quite more aggressive with prostates before. And so that's what creates that sort of nervousness, and the fact that living with it is a real option. And absolutely, we see letters as GPs back from the specialist that it is a small prostate cancer. We're not worried from the biopsy and the scan of where it is and what size it is and the type it is. And the treatment, the patients come and ask me, I'm not having any treatment, and the treatment is watchful waiting. And I'm sort of guided 3 or 6 or 12 monthly PSA checks just to monitor. And a lot of these men come in quite happily once a year or once every 6 months, have their PSA checked, and it's all normal. And it is a living with it one. Now, almost those men didn't need to know it. Didn't know.
It's conceptually really troubling to get your head around. But if you're listening and you've got a relative who's 80 years old or older, then the reality is that 80% of them and their friends, 80% will have prostate cancer. But in most of those men, it really isn't dangerous. But we do manage them differently. And in those men in the 80s, we do worry, however, despite what we've just said, if they have symptoms of more advanced disease. And that includes the weight loss, the bone pain, blood in the urine, or urinary symptoms have got a lot worse suddenly. And those are the ones that we do need to see. So don't despite our apparent relaxation about this, we're not. If you're sitting at home and you're worried about your prostate and you're in your 80s, then do go and get checked. But just be mindful that you probably don't need to be worried as you would have been if it was 20 years older. And we know that even if you've got advanced cancer, as I said earlier, the treatments are still extremely good. And it's still likely you'll live well beyond your natural life expectancy, even if you're diagnosed with it in your 80s.
Right, I'm going to come back a third time to screening. So I've aged now. I'm 50, and I know there's stuff out there, and you do that almost is drawing 50. Talk about risk factors, age. It's using 50, just starting to weigh the seesaw in not in the other direction, but starting to get towards the other direction. And there is some, not advice, there is some literature, some paperwork out there saying if you're over 50, have an informed check of your prostate and your PSA. And that really challenges us as GPs of this conversation about you are over 50, and that is, you have tipped slightly into a higher risk group, but you haven't got any symptoms, you're very well, you haven't got a family history.
So I think if we're towing the line that there is no screening program, I've said that 3 times now, I'm not going to beat that drum, but that's the form line. But saying that, I see a lot of men who have prostate cancer who don't have any symptoms, and they've been to see you as a GP and they said, I just want my PSA checked and it's high. And as we discussed earlier, lots of men in that position will not have prostate cancer, but there are some who have their PSA checked, is elevated, they get referred in, they have an MRI scan, a biopsy, and they do have prostate cancer and they do need treatment. And it goes back to the fact that PSA is not a reliable test. And even if your PSA is only slightly high, you may have disease that's significant enough for your consultant to recommend treatment for. So on a population basis, whilst the NHS doesn't recommend screening, on an individual basis, I see a lot of men who do ask for a PSA check, and I think it's a reasonable thing to do. We've said there are symptoms that you make as a GP be more worried about, and as a consultant I've been more worried about, and there's also risk factors. So if you've got the family history, or you're black, or you're older, then you will be more at risk of it. So that's something to discuss your GP with about. But when you go into that discussion, what your GP will say and make you aware of is that if you don't have symptoms, we can be opening a can of worms. And we generate a lot of anxiety. We may put you through an MRI scan. You may have a biopsy, and at the very least, a biopsy is not pleasant. but there can be other symptoms of biopsy, which include blood in the urine and urinary infections. So it can cause harm. If you get through all those hurdles, or rather all those occurrences with us, then we do see men who do have prostate cancer and it needs treatment and they have no symptoms. And I see a lot of men like that. So I think, my professional opinion is that, it's not a unreasonable thing to request, but you have to be informed, and your GP will discuss that with you and ask you about your symptoms and check your prostate as well. And as long as you've been informed, it is reasonable.
So I think that's the message, isn't it? Not to take it lightly. It's not just a simple book in, get my PSA checked, because although you're asking a simple question, you're actually asking a difficult question.
Yeah.
And there may be answers that you don't want to hear or you don't need to hear. Because often if I see a chap who, let's say 55, who comes in, who's worried because of a friend or not a relative has prostate cancer, and they want their check, and I have this conversation, and it's not a quick conversation. We have to run through a lot of ifs and buts and maybes, and uncertainties, and then we agree we're going to go ahead with the rectal examination and the PSA, and it comes back. We have some guidance where sort of age specific levels we check to, and if it's slightly higher, at that point I will call that chap back in 6 or 8 weeks time and recheck again, because as you alluded, if you've gone a long bike ride, if you've had some good sex the night before, then it can put things up a bit. But if it comes back a second time raised, then we are into your specialist team, with your specialist nurse, with the MRI, and potentially the prostatic biopsy.
Yeah, exactly, absolutely. So you say, you need to be informed that you could end up going down this pathway for no good reason. You could have even treatment and get significant side effects. And it harks back to the science. I'm thinking about Chris Whitty in the COVID era, when he said he just followed the science all the time, and that's what we're doing. We've got some very good, robust clinical trials that shows no benefit. Now, moving the discussion on, then there may be something on the horizon that will change the game. As you said, when you were at medical school, how many years ago, you were promised the next thing, and it may be coming. And what may be coming is MRI screening. So we don't screen routinely because PSA is not good enough. We've discussed that. An MRI scan is better, but we don't know that yet. So there is a trial that's starting to recruit next year. I think it's been run out of London. And then what they're looking to do is recruit men who have no symptoms of prostate cancer, and they will offer them an MRI scan. And they'll be looking to see if there's any change on the MRI of their prostate that could suggest prostate cancer. And we're hopeful that may be more of a reliable test than a PSA test.
It's been a long time coming, hasn't it?
It's been a very long time coming, and we need it. Boy, do we need it, because the tests we have at the moment are not good enough to get the answer we need. But if it does come, then who knows? In 5-10 years' time, we could be recalling every man 50, 60 years old for a one-off MRI scan, and that might really change things, and that would be useful and interesting if it did make a significant difference.
Yeah, often the chaps come in and talk to me and say to my wife has breast screening, my wife has smear screening, and why can't I have my prostate screen? And
discrimination.
I have to...
Exactly. That's what it feels like, isn't it? But the other thing to think about with prostate cancer is that a lot of men, because it's such a varied disease, you will pick up the high risk disease men who'll benefit from treatment, but you also pick up the men who would never have benefited from treatment in their natural lifetime. So not only will those men not get benefit, because had they not been tested, they would still have lived a natural, normal life and never known about prostate cancer. But worse than that, you may then offer them treatment that could cause them harm and side effects. It's a tricky one.
It is tricky, and so we've had a few questions already before we went live, and so I want to sort of post these questions to you, Mr. Tudor, and to say, and one of them you've addressed already. Is there anything I can do to help prevent me getting prostate cancer?
So the short answer is no. Broadly speaking, the risks we discussed, the things you can't change. There is some limited literature about certain foods like cooked tomatoes. One of the constituents in cooked tomatoes can keep the prostate safe, but I don't. It's not significant enough for me to recommend you all go and eat Mediterranean pasta and tomatoes every night is not significant. There's also some limited evidence that if you're a heavy smoker, that increases your risk of a dangerous prostate cancer, but not necessarily prostate cancer overall. So, as doctors, we're not going to sit here and miss an opportunity to tell you not to smoke. And if you come to need any treatment for prostate cancer, then not smoking makes the treatment more successful and means you're less likely to have any complications of treatment.
Just checking time. We might have to rattle through some of the questions. One, should I go private? Now, there wasn't any more to this one, so I'm not sure if this person was asking, should I buy a private test? Because there are ones you can buy in the chemist or on Amazon. Should I go and see a private consultant if I don't get the answer from my GP?
I would not recommend the private test on Amazon. They're not tried and tested. It's much better to go and see your GP for free, because we live in a country where you get your free healthcare. Go and book to your GP, have a chat with Jeremy, and get your PSA checked if you decide together that's the right thing to do. Private healthcare, of course, you can pay and see me. I work at the Nuffield. But the reality is that if you do, and I diagnose you with prostate cancer, I won't do it any quicker than I would on the NHS, because the 2-week wait pathway is slick. But more importantly, when you're actually diagnosed, and we haven't talked about this, we may not have time to, but when you are diagnosed, you don't just get me, you get the whole team, including a specialist nurse who will give you her contact card, and she is on call as your VIP specialist nurse all weekday, working hours. You can phone her about anything, any logistics, what's happening next, what test am I having, what's my treatment, but also you can say, look, I've been told I've got prostate cancer. I feel dreadful. I feel so miserable, as does my whole family. What the hell's going on? And she will offer a whole network of support, which is invaluable. And you don't get that privately in Gloucestershire. So I would stick with the NHS for this.
Yeah, I mean, I as a GP see the pressure across the NHS, but I absolutely see that the 2-week wait rules are protected, and the patients are very occasionally slightly over 2 weeks before the contact, but mainly it's churning through, and you guys are seeing those patients, and that's brilliant. And supporting.
Absolutely. I mean, we can refer patients into the NHS and the private sector. So if you do go private initially, we can refer you in, and you still get that benefit. But the reality is the 2-week wait service is generally pretty slick. So there's not a significant time saving to be made by paying your own money to go privately.
So going on from the PSA testing, and if you choose to have a blood test, I'm very aware that by having this conversation, we may well raise awareness and raise concerns. And I'm sorry if I've raised concerns, but we just wanted to get the message out there with some clarity, with an expert to talk us through. Because my concerns that I may generate more tests, we've actually set up a PSA Saturday. So Saturday, the 11th of May, so in 2 weeks' time from now, here at the Devereux Centre for patients at Tewkesbury, that's the Mythe practice and Church Street practice, Newent, Staunton Surgery, and West Cheltenham. We are offering a drop-in service between 9 and 11, and that's not just drop-in for a blood test. We are staffing with doctors and nurses here to have this conversation, to challenge, to make sure it's an informed test. But we are offering extra capacity. So you don't need to book. You can come in. We'll have lots of literature around as well, and we'll be here to answer questions. And some of you may come in and not walk away with a blood test, and that will be the right decision based on our discussion that morning. But very aware, we all wanted to put in some resource just in case we've raised sort of anxiety across the male population of what we call twins, Tewkesbury, West Cheltenham, Newent and Staunton. My eyes are not great. I'm just going to have a look at some of the questions.
Yeah, there's some good questions here.
Anne, did you have any questions that...
Should we start at the top?
Yeah, let's go.
My mother has glaucoma. I have annual eye tests. My father has prostate cancer, but I've not been called for a test yet. Why is this? Well, I think we've spoken quite a lot about screening, but that's what you're referring to. You won't be called up for a PSA test because there's no screening policy in this country. But if you've got worries, as we've discussed, please go and discuss with your GP.
I think the next one's about the MRI. It feels like the right way forward.
Absolutely. So surely MRI is the way forward. I was diagnosed that way following by a biopsy. PSA was only 6. So, that's an elevated PSA, but I see some men with very high PSA, so relatively it's very low. Yeah, and that's just a comment. I agree with you. MRI, the way forward. I mean, if this trial shows that MRI screening is beneficial, then the government's got a real challenge in its hand to roll out screening, because MRIs are expensive tests that need expensive radiologists to report them. But that's the challenge for the NHS, isn't it? But I think I agree with that comment.
Yep.
My paternal grandfather had prostate cancer. My father's been diagnosed. Do we know from trials if it is hereditary? Well, a clinical trial will look at treatments. I think based on that comment, that it depends on the age of your grandfather and your father when they were diagnosed, as I said earlier. But if they were, in their 50s or 60s, then you probably are at high risk of genetic prostate cancer. And I would recommend discussing that with your GP and getting a PSA check.
It doesn't say how old they are.
No, it doesn't say. A similar question. My older brother had prostate cancer 10 years ago, had surgery, currently been monitored. Younger brother has been diagnosed with early stage prostate cancer. How frequently should I be monitored? And again, we don't know the age there, but if your brothers were, in their 60s or 70s or even 50s, then I think that person should probably be having an annual PSA check. And the GP could take the lead on that and refer to us if it goes up. How is it confirmed as prostate cancer after all the tests? Well, that's what the biopsy is for. So the biopsy is where we take a sample of your prostate under local anaesthetic. Those cells go off to the laboratory and they're looked at underneath the microscope. And the pathologist can tell us these are cancer cells. So that's when we get the confirmation. And everything else we do, the PSA, the MRI, nothing is certain. It all gives us a likelihood, but nothing's confirmed until we get the biopsy. And when the biopsy result is back, I'll call you back into my clinic in Cheltenham Hospital and I'll see you with the specialist nurse I mentioned, and we'll give you the diagnosis and talk about the next steps then. Is there any diet correlation between prostate and diet lifestyle choices? Well, we've touched on that already. That's what we looked at earlier, wasn't it? My dad has a progressive prostate cancer and I'm at 56. I'm at higher risk. You probably are, unless your dad was diagnosed in his 80s. That doesn't mean to say you're at risk of significant life-threatening prostate cancer. But I would suggest if you're 56, you should discuss that with your GP and get a PSA check. And once you've got one PSA check, as if it's normal, it's very useful for your doctors to monitor the trend over time if you have ongoing PSA surveillance.
Yeah, that's a good one actually. So the one-off PSA for a chap without a family history, I often say, very reassured, we've had a chat, you're low risk, you haven't got any other, you haven't told me anything worrying. I've done your rectal examination, I've done your PSA, it's 1.5 or 2. Then the patient asks me, brilliant, when should I check again? And I'm going to throw that challenging question. Now,
so it is a challenging question. The reason it's challenging, even for me as a consultant, is that there's no guidelines, and it all goes back to the fact there's no evidence for screening, which we spent a lot of time discussing in this session. I think you've got to be pragmatic. There is the thresholds are very black and white. So we say that for men in the 60s, the PSA should be less than 3.5. Men in their 70s, less than 4.5. Sorry. Men in their 50s, less than 3.5. Men in their 60s, less than 4.5. Men in their 70s, less than 6.5. So the natural sort of allowable PSA increases in a stepwise fashion over time. But of course, the body doesn't increase in a stepwise fashion, and prostate cancer doesn't obey those rules. So your PSA will increase naturally as you get older. So if you've got a PSA that's normal but just below the upper level, then you can take reassurance that at that stage in your life, you probably don't have a significant prostate cancer, but it would be prudent to have your PSA checked, certainly the year after, just to make sure there's no significant fluctuation.
But this is the real challenge to me. So if I see this chap who's 55, he's got no symptoms at all. Unfortunately, his friend at the golf club had prostate cancer, so he's coming for his check. We've had this informed discussion. His PSA is very, very normal. My interpretation was that at that stage, I reassure him as much as I can. I cannot say
he wouldn't need referral in to our services if his PSA is normal,
and then
unless there's other worrisome symptoms you've got.
And then I would recommend, look, we know your baseline. If you were to get any change in symptoms, then I definitely want to see you, and then I've got a comparator. Absolutely. But I wouldn't normally call that chap with no symptoms at all?
There's no strict guidelines, and that's a correct approach. I mean, you would take a history, you'd ask about those risk factors, the family history, and that might make you more worried if the patient's two identical siblings had got prostate cancer. Then you may be more worried as a GP and want to check the prostate PSA level again in a year's time. But there really aren't any rules, you know. And I see some men in my clinic who've managed to persuade their GPs to an annual PSA check for years and years, and some men who have it a one-off and then they never bother their GP about their prostate ever again in their lifetime.
Yeah, because it almost feels sometimes that we've sort of been backed into a screening program that isn't backed by NHS England, and that's the awkwardness that. And I mean, I imagine lots of different things are happening across the country, and we're trying to keep that sort of equity for men, even across Gloucestershire.
And of course, the challenge that we have as NHS workers is that, and this is not something that we as, you know, at the coalface GPs and consultants have to contend with, thank goodness, but the NHS has to decide where it directs its resources, and you know, that's what you've been alluding to there. You know, we can't offer every man a PSA check every year. But if you need to see a specialist, then you will be referred in. So don't get me wrong. You know, money is not an issue in this situation. But I think, you know, if a man has a PSA check and it's within the normal range, but at the top end of the normal range, and he's young in that age bracket. So, for example, a man in his early 50s have a PSA of 3.4. Whilst it's the upper limit of normal, it is normal. So that man can be reassured. But it might be sensible to recheck the PSA again in 1 or 2 or 5 years. Yeah,
that's shades of grey, isn't it? That you're normal, but only just normal. So it then becomes a bit more of an art than an exact science.
Exactly. That's where our job becomes more of an art, and that's a real struggle for my patients. We haven't really touched on treatments, and of course, most of the patients I end up seeing have gone through that pathway we discussed. By the time they see me, I am talking about how we're going to treat them once they've got a confirmed diagnosis of prostate cancer. I would like to say that actually the majority of men I do see at that stage, their disease is treatable. We've caught it early, and it is treatable, and we achieve a cure, and they can live a normal life expectancy. But even for the smaller group of men who present with incurable disease, the prognosis is not dreadful. The drugs we can give are very good now, and most men are living 5 years at least, which, you know, that sounds very scary, but, you know, I think the media doesn't always help, and prostate cancer or cancer is often viewed as a death sentence. And there are certainly some types of cancer that are more aggressive, like pancreatic cancer, for example. But prostate cancer really isn't like that. Even the more aggressive types that have already spread, there is a good 5-year survival, or a good long or medium-term survival. But for most of the disease that I see, it is treatable, and the long-term survival and cure rate is excellent.
I mean, I think we're going to have to come into land, but
of course,
I guess there's that notice about how do we manage prostate cancer. The vast majority of patients that I see, they're being managed hormonally, actually, and they're living their life normally, and they're having hormone blockade via an injection from our nurses, such as Anne here. Can you tell me which of those groups that you offer surgery to? Who were they? So
we offer surgery to men who have disease that hasn't spread. So the disease is contained in the prostate, and we caught it early. And that is the most of the men that I see. Most of the patients who are diagnosed with prostate cancer have disease that hasn't spread, because we do catch it early. So that's the first thing. The second thing is that surgery, we tend to offer it to men in their 50s and 60s and early 70s, who tend to be fit. You know, that doesn't mean you have to be able to run a marathon, but it means that, you know, you're a normal person living a normal life with a normal exercise tolerance. So you can go on, you know, a 10-mile walk without breaking too much of a sweat. So you've got to have disease that's amenable to the treatment, which is localized disease, and you've got to be fairly fit for it. The other treatment that we offer in Gloucestershire and the country is radiotherapy, which is a non-surgical alternative. And the good news for patients is that actually we know from the best studies that we have that whether you have surgery or radiotherapy, the success rate, the cure rate is equal and excellent in both groups. And without delving into clinical trials too much, the best study we have looked at men put into those two groups, surgery or radiotherapy, men with localized prostate cancer, and it followed them for 15 years. And after 15 years, in both groups, about 95% of men were still alive and well with treatment. So the treatments work, it's treatable disease. But surgery is not without its risk.
Yeah.
And some of the common long-term risks that we help men with, and most men do recover from, are incontinence and also problems with erections, erectile dysfunction. Now, both of those conditions are treatable. But we do find that more elderly men in their 70s, they do struggle with those symptoms more. So if you come to see me in my clinic, we will talk about surgery, but I tend to recommend that radiotherapy is often a better choice. And younger men can have radiotherapy as well if they wish, because we know from that study I mentioned that it's equally effective. But that's a real challenge for me. So you as a GP have the challenge, do you check the PSA?
Yeah.
But then these men, they come back to see me in clinic, and I sit down with them and say, look, we've done your biopsies, they confirm prostate cancer. Of course, that's devastating news. It's never what you want to hear. But then the poor man has to make a decision about the treatment option, because I'm there saying, look, you've now got to choose. Do you want surgery or do you want radiotherapy? And that can be a real struggle, because a lot of patients are quite used to their doctors saying, this is what you need, this is the right thing for you. And we as doctors in general are trying to move away from that paternalistic approach and give patients a choice. But it's not always helpful. I think some people in that overwhelming moment, they're like a rabbit in the headlights. They want someone to tell them what to do. But I can advise. But what I say to men is, look, you don't have to make a decision now. You can go away and think about it. You can speak to your GP. You've got a week or so to make a decision. Do you want to have surgery or radiotherapy? But also, as I mentioned earlier, you get that specialist nurse allocated to you. So she'll give you her card. She will phone you up. And it's a bit of a debrief. A bit like you are constrained for time in your clinics, we have the same challenges in secondary care, and we give patients the time they need. But sometimes, understandably, there's many more questions that come out, especially when the dust has settled. You get home, you discuss the diagnosis with your family, and you think, what about that?
Yeah, I mean,
and the nurses do have time to
really appreciate that option, because it's just, I mean, obviously you're used to the hospital, but for some people who don't go to the hospital, it's quite daunting.
Of course.
And some people don't want to ask questions, but actually get back home and, we should ask the question, and that's the nurses work brilliantly to help with that.
Absolutely.
So we've covered a heck of a lot tonight, and I hope everyone appreciates this is the challenge, that it's not a quick 5 minutes chat and done and dusted. We have to explore, and we do have that option that we've talked about for Saturday the 11th of May here at the Devereux Centre between 9 a.m. and 11 a.m. We will have doctors, we have nurses, we will have phlebotomists taking blood tests, but we will want to have a chat. We'll have lots of information. We've got posters here and we've got leaflets. And so we just want to have a chat with guys, because it is treatable.
It is really treatable.
Yeah.
The treatments work really well for prostate cancer. So that's one of the privileges of the job that I'm in. We do get men better, and be able to tell someone that they're cancer free is the highlight of the job. And we do it. We do it. But the process is scary. It's daunting. But the point is, you're not on your own. There's a huge team of GPs, consultants, and nurses who are here to look after you. And our job is to get you better. That's what we do.
So a massive thank you to Mr. Tudor, who's been operating today, has come over this evening to help us out and just to demystify and sort of verify some of the things that we're doing here in primary care, because we are here to help you, and we want to make sure we're helping you, the right people, to see Mr. Tudor.
Yeah, you're very welcome. It's been a pleasure. Thanks for having me.
Thanks so much. Cheers.
Thank you.
Thank you.